Hi, folks. Let's go ahead and get started on chapter one. Before anything else, of course, make sure that you've got a pad and a writing implement when you're doing your studying so that you can read and write. Look, if you got to recite it as well, that is a good recommendation. But the idea is that when you go into your actual study time, that you are using a pad to write on and writing implement so that you get that read and writing component of the study that we recommend. So we're going to go ahead and get started here on chapter one. And chapter one in the 7th edition of NASM is, as in the other editions, is going to be more of an introduction than anything else. However, in this chapter, Modern State of Health and Fitness, NASM is actually giving you a lot of really good preliminary information to help you understand and appreciate what you're going to be getting yourself into as a trainer, because it's a new world in healthcare, and that's basically what NASM is kind of explaining in this first chapter. So their learning objectives are going to focus on identifying chronic illnesses, or at least the most prevalent chronic health conditions that are affecting modern Americans, and then differentiating between evidence-based information, right? The science behind why we do what we do versus fitness fads and the myths that are still quite prevalent. And so it's really important that you read through this introduction, because that last part is really, really important. Even in today's sort of modern scientific way of understanding health and wellness, there's still a bunch of misunderstandings and myths surrounding, how to lose weight, how to gain lean muscle mass. And so we definitely want to kind of get through that material, appreciate it, understand it, and understand why the scientific rationale for training is the way it is. And that's what you're going to get here in chapter one. And so the first thing they're going to start with on page 3 is evidence-based practice. This is very much in sync and synonymous with what we know the healthcare field has been doing for literally decades, always trying to find the best practice, those things that other professionals in your field are doing, right, that are showing really good results or best practice results. And so it's always going to be based on the evidence that you get by doing what you do and getting results. And that evidence then is going to be used to then be incorporated into whatever other professionals are now going to do. We call that evidence-based practice. If we use certain type of medicines, and then over the course of time, we collect historical data on how certain medicines affect people and the chronic issues or what other issues they have, at least in medicine, then practitioners, as time goes on, will look at that evidence and go, you know what, apparently this is what's working really well. We're going to go ahead and use that as well. That's called evidence-based practice. And so the scientific principles that are involved with training and nutrition, all of those things, is what we now want to use. And that's what we're going to go over in chapter one. And so evidence-based practice, it's based on kinesiology, which is essentially human movement studies, or the study of human movements. And the idea is that we train people, we use resistance training, or whatever the case is, based on not what we see some other folks doing, even though they may be doing it correctly, but we use evidence that the scientific data that we have collected is going to allow us to help other people. And so we do that through the science of kinesiology and evidence-based practice. So that's going to be that very first part of chapter one, to kind of get you primed and ready for what obviously is going to come ahead. And then they're going to go straight into, on page 4, the integrated training and the OPT model. Now, just so you understand, the optimum performance training, or OPT model, is the sort of trademark for the NASM brand. And that's what they're going to use consistently throughout the rest of this textbook, which is why chapter 1 is so important. It's a proprietary approach is what they're going to say to actually helping people move through the different stages of the training that they're going to need to go through. They're giving you a basic overview in chapter 1. In other words, they're not going to get into the specifics of the OPT model, but it's a good idea when you're going through this to get an appreciation and to memorize, right? To memorize the 5 phases of the OPT model, which is going to be stabilization endurance, strength endurance. And then they made a change from their previous edition and use a new term. Instead of using hypertrophy, right, muscular hypertrophy, they've changed their phase 3 to muscular development, which is part of the stage 2 or strength stage, maximal strength, and then power. So just a little change in terminology. And as we continue to go through, they're going to shift now into the global state of health. So chapter 1 is really giving you a sort of general explanation of what's going on in the state of health and wellness in our country, for instance, and how we can tackle that as trainers, and then move on from there. So the global state of health, defining health and disease. It's important to understand how we define health itself and what a diseased state is, and the basically two types of diseases that people have, which are going to be acute issues, right? Problems that occur, such as you break a leg, that's an acute injury, right? Versus chronic illnesses. And so chronic illnesses is basically what we're looking at in the health and wellness industry because of poor lifestyle and eating habits. And so what NASM is doing is they're giving you information, particularly on page 7. There's a couple of figures that are going to give you data on the actual diseases. Not that you have to memorize that, but it's not a bad idea to take a look and really appreciate the fact that heart disease is the #1 killer, and they tell you this, leading cause of death, not in the United States, but the leading cause of death in the world today are classified as these chronic diseases and conditions. Coronary artery disease is leading cause of death in both men and women. So it's not a bad idea to understand and look at these. You're not going to need to memorize them, but you do need to know what we're dealing with. Again, as a health and fitness professional, as a trainer, knowing these things, appreciating these things is one of the things that's going to help you to maintain your passion, hopefully, and interest in what you do as a trainer. There are risk factors that go along with these chronic diseases, and that's basically what you're seeing all the way through these next couple of pages. Physical inactivity. So now NASM goes into what are kind of the causes of this? What are the risk factors for these chronic diseases and issues that we see? If you don't know this, then it's hard to make that connection between lifestyle behavior management and change, right? Exercising and eating well, and how that impacts and affects people with these chronic illnesses. So we know, and that's what you're getting here in chapter 1, is we know that certain things that people do and things that people do not do in general on a daily consistent basis is what's causing, for the most part, these chronic illnesses that we see. Now, the cause and effect component is not as well understood. In other words, we can't specifically say that one particular thing that a person does or does not do literally causes this chronic illness. We know that it's a collection of causation that leads to these chronic illnesses. So again, without getting too deep into that end of it, the idea is that because of physical inactivity in the general population, we know that there's going to be a propensity, or there's a risk for getting these chronic illnesses. And that's basically what chapter 1 is going over. And now they're going to get into the actual, on page 9, they're going to get into the actual chronic diseases, or the most prevalent chronic diseases. So being overweight and obese, one of the things that you definitely want to know and remember from chapter 1, and they're giving it to you, and they're going to repeat it consistently throughout the rest of the textbook, are your BMI classifications. Please keep in mind that the concept of BMI or a BMI or body mass index has been used by the clinical medical world for a long time as a classification to kind of determine risk factors for these chronic diseases. And the term obese means that you have a BMI. It's not that you're, quote, fat. That's not what BMI is saying. BMI is saying that there's a relationship between how tall you are and the total amount of mass or your weight compared to that height. Okay, we know, of course, that bodybuilders and weightlifters, just as a for instance, will have much higher BMIs because related to their height, right? They're a certain height, but they've got so much muscle that their physical weight is much higher. So if I never looked at this individual like a competitive bodybuilder, every single, by the way, professional competitive male bodybuilder is by definition obese based on BMI. But obviously they're a completely different animal because the total amount of body fat they have is actually less, significantly less than the average population. So chapter 1 helps us to make some clarification in terminology, and that's why it's important. So table 1.1 is going to give you BMI and what the classification is. You are obese. Okay, I was at, as a competitive bodybuilder, obese for many years. Okay, but that classification really had no real connection to my overall health. So BMI is used as a very broad generalization for the average person, not a bodybuilder, right? We're not going to classify athletes and those individuals with high levels of muscle mass and worry too much about their classification. This is really designed to help you understand from a clinical perspective. This is the clinical classification system, what it is we're dealing with when we're talking about the average person and their body weight compared to their height. It's very general. We don't want to overstate the importance of this, but we also don't want to not know it. It's critical. Okay, so this table 1.1 on BMI let's let you know a little bit about the numbers. So the classic number is 30 and above is clinically obese. If an individual is between 25 and 30, okay, they are clinically overweight. Now, once again, remember, we're trying to move away from just common terms that are used. Somebody's overweight, or, well, yeah, they may be overweight, but that's not the clinical term. The clinical term overweight means that they have a specific BMI. So that's the professional usage of these terms. Obese can be actually classified in three different levels. Your technically, first level is just obese, and that's if you're 30, BMI is 30 to 35. 35 to 40 technically is class 2 obesity, and in class 3 obesity is when your BMI is higher than 40. So those are the different classifications. Very important that you know that. And then of course we get into another prevalent chronic illness, which is heart disease, arterial sclerosis. And so it's important to kind of keep in mind that there are specific actual clinical diseases like stroke, heart attack, heart failure, and there of course are some sidebars that you would like to read and know. The more familiar you are with page 11 and the sidebars that go along with this, actually the better it's going to help you as a trainer, so you can work with folks based on based on whatever clinical diagnosis they got. And boom, we're moving over next page into arterial sclerosis. And then how is physical activity connected to that? Hypertension is going to be another. So kind of think about this. Some of these prevalent chronic diseases, right? So obesity, it leads to other issues and problems. Heart disease, hypertension, right? Hypertension is basically what we call high blood pressure, right? So hypertension is the clinical diagnosis. It's based on understanding the pressures that are involved inside the arterial system. So we have what are known as the systolic blood pressure reading and the diastolic blood pressure readings, right? And if you've seen blood pressure, most folks are familiar with this, right? The diastolic is the number on the bottom. The systolic is the number on the top. So we normally know the 120/80. If you haven't been under a rock for very long, you know that blood pressure readings, the standard, or at least up until recently, the standard reading of 120/80 was normal, and that's changed a little bit. And they're going to actually go into that a little bit further in the text, because the clinical world has established, right, through data and information and research, that the numbers needed to be modified a little bit to stratify the risk a little bit better based on the data that we continue to get in clinically, right? So hypertension has a systolic and a diastolic number, the 120/80, whatever that number is, it tells us something about the pressures that are present inside the arterial system. And so the systolic blood pressure is normally understood to be the pressure of the fluid, i.e. the blood, that pushes out, right, on the tubular artery, right? So the pressure that is pushed out every time the heart, right, or the left ventricle contracts and pushes blood out into the arterial system, there is an increased pressure. That's the systolic pressure. So that's that top number that we see in millimeters of mercury is the standard that's used. And then the diastolic is when the heart muscle, right, has gone through its initial contraction and now relaxes, or at least the left ventricle relaxes, blood fills the ventricle, and the arterial system squeezes back down, right, to continue pushing the blood through the arterial system. There is a pressure now associated with that relaxation of the heart and the squeezing of the artery, which are muscles, back to normal before they're going to go through the next round of increased pressure being pushed out. So there's pressure pushing out, and then that pressure that's associated with the arterial system coming back down to its normalized state. That's called the diastolic blood pressure. Those two numbers together, 120/80, 130/85, whatever the numbers are, they tell us something about the overall health, right, of the cardiovascular, in particular the arterial system. So knowing those two numbers are critical when it comes to getting a bead on an individual's overall cardiovascular health. And that's why we have those numbers. Again, on page 12, you are getting the new guidelines for blood pressure. Normal or a healthy blood pressure is less than 120/80, and that is a critical differentiation between what we had previous, which was 120/80 was the starting number. Now it's technically it's 119/79 is healthy. 120/80, we'll get into that, but it's a good idea to get a sort of a preview of this prior to moving into the rest of the textbook. Cholesterol levels, and there's a little sidebar stretcher knowledge on good and bad. Now, I will say it's actually important to understand why they're saying good in quotes and bad in quotes, because there are two types of two main types of cholesterol, and they want to make sure we understand that this idea of good or bad is really relative, and it's based on those numbers themselves, but also the correlation with other variables. Again, it's without getting too deep into it in chapter 1, it's important to understand that there's no one particular variable in the apparently healthy individual that causes chronic disease. It's a multiple grouping of risk factors, okay? So we just got to keep that in mind. That's why it's helpful when you're going through chapter 1 to keep these things in mind. More than likely in chapter 1, you're not taking a lot of notes, but it's not a bad idea to write some of these things down so you have them in your, in your storage bank, memory storage bank, as you move through the rest of the textbook. Diabetes, cancer, respiratory, these are all of these now. As we move through the rest of this chapter, there's going to be less and less material written about them, simply because the overall effect that lifestyle has on them may not be as prevalent as we know it's going to be with obesity, for instance, and cardiovascular disease. So again, as we move through page 14 and page 15, we get to sort of these last prevalent chronic or disease states that people are going to be in, and it ends with stress. Okay, evidence of muscular dysfunction and increased injury. Now what we're doing is in chapter 1, moving towards more of the sort of musculoskeletal issues that you're going to see more than likely with the average person. And so as we come basically to the end of chapter 1, we're hitting a general explanation of some of the problems or dysfunctions, right? Dysfunction is a really good term to keep in mind and memorize as we're going actually through the end of the textbook. As you get through it, this concept of dysfunctions is in my opinion a better way of explaining the issues that we see when the average apparently healthy individual walks in and wants your training services. So starting from kind of the lowest part of the foot and the ankle, lowest part of your body, and moving up through these main joint areas of your body, ankle and foot dysfunctions, right? Plantar fasciitis. Now, again, keep in mind, in the clinical world, we see hundreds of different problems and dysfunctions when somebody comes into a doctor's office. What we are seeing as trainers, here's some general information about what we will generally see. And I think over the decades that I've been doing this, yeah, there's only a couple of things that, number one, I see or I have seen, and that I could even help or assist with when it comes to dysfunction. So at the foot and the ankle, somebody has an ankle sprain, for instance, I'm sending them to the doctor. I'm telling them to go see their doctor. But these are the things that we see. Plantar fasciitis, again, another dysfunction that's going to cause issues or problems when people are looking for training. Knee dysfunctions, things such as patella tendonitis, medial collateral ligament issues. Now, this is where, if you don't know some of the terms, this is a good point of reference now to start kind of thinking before you get through the rest of the textbook about definitions and some anatomy. That's a good idea to start brushing up on, so to speak. ACL tears, PCL tears, MCL tears. Those are, if you're going to have knee injuries, these are going to be some of the more common ones that you would probably see. And then you have the LPHC, all right, lumbopelvic hip complex. And what are the dysfunctions? Just a little hint here, more than anything else, that's where we see most of the problems, or I've always seen problems with clients, is going to be in this midsection area, the lumbar, right, the lower back, the pelvis, the tilting and issues. And it's one of the reasons why it's a really good idea to start getting your brain thinking about the importance of of these dysfunctions, thinking of the importance of knowing and being able to quickly assess. That's why we do assessments. Okay, shoulder dysfunction, shoulder impingements, and now look, there's a bunch of issues that you're going to see people dealing with, not only when they come in to train with you, but as well as if through the training it's not done properly, they can actually incur injuries. Head and neck dysfunctions. If you don't realize it already, you're already into what are called the 5 kinetic chain checkpoints, and that's what they're showing you right here, that the major kinetic checkpoints on your body are going to be head and neck region. These are where the main movement patterns occur. Shoulder, right? Scapulo, shoulder area, right? The shoulder girdle, the hips, the waist, the pelvis, the knees, and the ankles. Those are your main kinetic checkpoints, and you're going to hear a lot about that, obviously. And so now the question, and this is where chapter 1 starts to bring to a conclusion, is where do we fit into in the healthcare continuum? We have what are known as the allied health professionals, and those are, by the way, on page 18. You get a figure of all the different areas in sort of the medical community, and then you're going to see health and fitness specialties over to the bottom right. And this is pretty cool. This is pretty cool because we actually are, or at least should be, viewing ourselves within the healthcare continuum. And for a long time, for many decades now, many of us that have been in this for a long period of time, we've been trying to figure out, how do we get ourselves into the healthcare continuum? How do we help people along with their doctors and their therapists? How do we help them to help people? We know that we're not going to be dealing with medicine or prescription drugs, things like that. But how can we do it? And this is what NASM's kind of giving you a little overview on. And you should think about it from the healthcare continuum perspective. We fit in there as well. We should. So the allied health professionals, look, you don't need to memorize exactly what they do, but it's not a bad idea to understand where they fit and what their particular functions are, because it's important that you know who you can refer people to if they do have some issues or problems. Normally what I've always done is I will tell people, look, you've got a primary care doctor, and that's your quarterback, right? So think of the primary care doc as kind of the quarterback in sort of this interprofessional scenario that we all find ourselves in. I'm not going to tell an individual, well, go see your nurse. It's not how it works. From a medical perspective, it's always going to be the primary care doc. That's normally the quarterback that starts and decides where the individual patient is going to go. If you don't have one, okay, well, there are chiropractors for musculoskeletal issues. There are dietitians, nutritionists who can help, for instance, with the nutritional component. These are the individuals, right? Massage therapists. These are the individuals, because of their extensive education and background and training, right? Hopefully lots of experience, you can look to and make connections with to tell your clients to go see if it's out of your scope of practice. And then this is where now certified personal fitness trainers come into play. And page 19, role of the certified personal trainer, and just a brief intro on the scope of practice and code of conduct on page 20. Please read through that. Make sure you're comfortable, you understand the scope of practice of the personal trainer. Now, here is where on page 21, you really want to slow down and spend a little bit of time and understand what the NASM Code of Professional Conduct is all about. So look, it's not a bad idea to, at this point, they have it listed in bullet points, to write some of this down. You really need to be on point when it comes to understanding exactly what your code of professional conduct is as a NASM certified trainer. Once you get certified by NASM, you fall under their purview and basic jurisdiction of code of ethics and professional conduct, as well as scope of practice. So it's a good idea from page 21 and page 22. There's a legal and ethical explanation and your business practices. NASM in their book, in their textbook, has given you a nice chapter review. I highly recommend you read through that, and then read through their chapter highlights, because they have bullet pointed, basically an explanation of what's gone through the chapter. Now that concludes chapter 1. Again, keep in mind, it's important to read through the chapter, spend a little bit of time on those points that I did go over, and we'll see you next in chapter 2.